Hey, welcome back everybody. It's Dr. Brooks here with Chapter 10, Tissue Response to Injury. This is Screencast 7 if you're following along. Uh, Much like last time, this chapter is an important foundational chapter that will set the ground rules and the guidelines for injury and healing as it applies to each of the specific body parts that we'll cover later on in the course. So whether you're talking about an ankle sprain or a shoulder dislocation, doesn't matter. If we understand how the tissues respond to trauma, then we've got a pretty fair understanding of how that specific injury is going to heal and what we can do best to facilitate that healing. So it's critical for athletic trainers, or for that matter, if you're even, you're taking this course as an elective, you want to be a physical therapist or you want to be a physician. Regardless, if we're in the healthcare field, it's critical for us to have an in-depth knowledge of the healing process. And understanding those phases and the typical time frames, the physiology involved, can help us create an optimum environment for healing. Now, the healing process, it can't be skipped. We can't magically jump through into recovery and remodeling. It's a continuum, and understanding what to do to best create that environment is the key difference between a good clinician and a great one. So understand that, this is out of your textbook, we've got this initial inflammatory process that lasts anywhere from 1 to as long as 4 days. Somewhere around day 3, we end up with this fibroblastic repair phase, this intermediate phase that basically heals the injury or stems the injury from worsening, but it's not a long-term fix. And then somewhere around week 4, week 5, we begin what takes a long time to complete, and that's the maturation remodeling phase. Now, during this inflammatory phase, we've got a number of things that occur here that we certainly want to treat. So we look for these as what are referred to as the cardinal signs of inflammation. Ruber tumor, Calor, Doler, Functio, Laecia. These describe those cardinal signs. So we end up with discoloration or redness. We end up with swelling, heat, tenderness and pain, and then lastly loss of function. So this inflammatory response actually occurs in 3 distinct phases. The inflammatory response, rather, is one of the 3 phases. Okay, and so we're going to take a look at it first. So healing begins as soon as injury occurs, believe it or not. Now, we might not necessarily recognize it, but those signs of inflammation actually serve a physiological purpose. Okay, so we end up with metabolic changes, and we get various materials, waste products of injured cells that have to be cleared from the area in order for healing to occur. Now, you can think about an injury much like a construction site. So in order to build a new building in an old area of town, you've got an urban renewal project, something like that, first we got to tear down things that aren't useful anymore. So this initial inflammatory response is intended to protect the area from further harm, localize the damage as much as we can so that we don't get collateral injury, decrease things that might trigger secondary cellular death, and then prepare the site for healing and repair. Okay, now this has occurred in a number of pretty complex mechanisms and ways. So first we get these chemical mediators. If this is an infection, then it's stimulated by the pathological agent. If this is an injury, then there are some chemical signals that the body will send out in order to trigger this inflammatory response, and that may come from the destruction of cells during that injury moment. We get a histamine release. If you've ever had allergies, you know what histamine does. It causes that allergy type reaction. We get vasodilation, we get changes in cell permeability related to swelling. The leukotrienes and the prostaglandins also impact marginization, so this will certainly influence the rate at which things can cross over cellular membranes. We get an increase in the permeability in those membranes for fluid and protein passage. This is referred to as diapedesis. This leukotriene and prostaglandin regulation also facilitates the formation of neutrophils and their entrance into that injured site so that they can begin the process of rebuilding. And then our cytokines regulate those leukocytes, those white blood cells, and attract those phagocytes that are going to be responsible for getting rid of those waste products. Now, in addition to a chemical response, we have a vascular response. So as you saw from this chemical mediator response, we get a lot of changes. Well, that has to be transmitted or transferred. If we're altering permeability, then we are also needing to change transport within the system so that waste products can be filtered out and so that nutrients that are necessary for healing can be brought in. So initially during this inflammatory response phase, we get a vasoconstriction and coagulation, so that if we've got injured blood vessels, we minimize the amount of swelling, bleeding, otherwise fluid accumulation in the area. Okay, so this vasoconstriction presses those endothelial wall linings together so that we end up, relatively speaking, with a local anemia. Okay, so this is immediately. Okay, and then 5 to 10 minutes later, we may get a vasodilation. Once the bleeding has stopped, and this, when I say bleeding, I don't mean external that needs a band-aid. Say you sprained your ankle. We get an immediate vasoconstriction that the body intends to minimize swelling, minimize damage around the area. And then we get vasodilation. So we see those temporary vasoconstriction responses are reversed. Okay, vasodilation results because we already had the platelets and we've had some clotting occur. So we get an alteration in blood flow here. The blood viscosity actually goes up. It's relatively thicker in the area. So we end up with this change in local circulation, and in many ways this swelling is intended to try to eliminate or minimize additional movement that might further exacerbate the injury. Now, unfortunately, most of the time our athletes, our active patients, don't heed that, and they will try to play through. Okay, so we get this injury to, let's say it's a ligament cell in our ankle. So these chemical mediators are released. That results in this vascular reaction. We get this initial vasoconstriction followed by vasodilation, and then we end up with kind of this static change so that nothing really changes. The end result here we see is phagocytosis results in cleaning of the debris, if you will, and then this clot formation forms kind of a temporary plug so that we can minimize further losses due to a lack of oxygen. Okay, so clot formation is actually a pretty remarkable process, and if you know anyone who's had a bleeding disorder where they were unable to clot, then you know just how important this can be. The platelets within the blood will adhere to the exposed collagen fibers and form this initial clot. Obviously, we know that is pretty tenuous. It could easily be disturbed. The clot obstructs the lymphatic fluid drainage, and it helps localize the injury response just to the immediate vicinity. Okay, now this fibrinogen has to be converted to fibrin in order for this blood clot to take a more permanent, a little bit more durable form. Okay, so if we notice, we've got these leukocytes in the area. Once this injury occurs, these macrophages are brought in, and the fibroblasts are called into action, and we also have the neutrophils here. So the initial tissue insult triggers all these changes, and they are intended to really do two things. A, to minimize bleeding, and in this example, to minimize additional losses, and then also to mobilize the structures and organelles, or rather the components that are necessary to help that rebuilding process. Now, we can get stuck in a period where inflammation lasts well beyond its usefulness. Okay, so early on in the injury process, inflammation can serve to prevent us from worsening the condition. However, when that inflammatory response doesn't eliminate the injuring agent, then it's said to be chronic. Okay, if it persists, then we actually start to have tissue death, necrosis, and then fibrosis, where we get scarring that makes that healing process take even longer. Okay, the cause for this shift from acute to chronic inflammation really isn't known. Sometimes there's just really not a valid reason for that inflammatory response to persist. But oftentimes in athletics, it's due to improper loading. The athlete continues to try to participate through even when they shouldn't. Now, as I've shared with I think I've shared in this class before, I'm dealing with the healing process associated with a stress fracture, stress reaction. That initial inflammatory phase I tried to run through. I thought it was something different. So as a result, my inflammatory response turned somewhat chronic. Okay. Now, lots of times this is going to be associated with overuse or overload or cumulative microtrauma. So we can't really pinpoint one particular instant when the injury occurred, but we just kind of habitually overloaded the tissue. Okay, so this blood clot eventually will heal from the inside out, and we end up with this scar tissue. Okay, as long as we don't have further insult to this tissue, this could be allowed to proceed. This is sometimes referred to as fibroplasia, where this scar is formed, and we end up with this granulation tissue, and then over time it's going to slowly heal. Usually during this time, complaints of pain and tenderness will gradually decrease as that injured tissue slowly heals. Now, in order to continue to heal, we can't stay in that inflammatory phase, with the exception of a chronic inflammation where we kind of stay there. We're trying to progress to the later phases in this process. So phase 2 is the fibroblastic repair phase. And with this, the generic tissue or cells that were used to stem the flow of blood, in this case, are slowly replaced with collagen. There are 16 different types. The body contains 80 to 90% of its collagen is type 1, 2, or 3. If we go through the normal sequence of healing, there's minimal scarring. Okay. If, on the other hand, we've got this persistent or chronic inflammation, then we may end up with what's referred to as extended fibroplasia. Okay. So during this time, as long as we are encountering forces, then that tissue is going to remodel. On the other hand, if the force is too great, then we're going to break it down at a rate that exceeds the rate at which it's remodeling. Okay, so this is where, and we'll talk about this term quite a bit more in the future, optimal loading comes in. Okay, we used to talk about RICE, rest, ice, compression, elevation. The problem with that is that rest alone isn't enough to cause this collagen to remodel optimally. Instead, we're going to end up with a permanent weakness as a result of the injury. On the other hand, police protection optimal loading ice compression elevation means we're going to prevent further tissue insult, but we're going to load it such that we get increased strength in the tissue. It's going to remodel appropriately. Instead of just garbage tissue, it's going to look more like the tissue that it's replacing. So we refer to this as progressive mobilization. Okay, so early on in the process, it may very much look like rest. There may be very little that we can do. So an ankle sprain, for instance, we might have the athlete do circles on a wobble board, very small oscillations with some active movement. And then as they continue to heal, we may increase the height at which that wobble board is set so that they're doing greater range of motion. But unless it is something that absolutely contraindicates force, a broken bone in a cast, there's very little we can do because we can't bear weight. It has to heal. So during remodeling, we want to be as aggressive as we can be with range of motion and strength exercises. Even if we're in a cast and we can't move, doing isometrics can be beneficial. We've got to be aware of how our exercise prescription is causing this maturation and remodeling to occur, because too much too soon can result in significant swelling and pain. Okay, so that's what we're constantly looking for. We want to push as far as we can without overtaxing the tissue. So a number of things can impede healing. First of all is the extent of the injury. The more severe the injury, then the longer it's going to take. Many of these other things, you kind of understand that no two tissue types are the same, and cartilage, for instance, has a much poorer blood supply than muscle. So we know that if it's a cartilage injury, it's probably going to take longer to heal. Some other things maybe we can't control as much if they've got an infection. Health, age, and nutrition, that last one you see there, absolutely critical. You could even add sleep into the mix. If a patient isn't sleeping and they're not taking in the raw materials it takes to heal, then that's going to make it very difficult, and they are going to heal slower than their well-slept, well-nourished counterpart. All right, so we've talked a lot about tissues. The 4 types of soft tissue. Bone is not classified as itself as soft tissue, but 4 types of soft tissue: epithelial, skin and vascular, connective tissue, muscle tissue, and nervous tissue. Maybe a little confusing there to see the musculoskeletal system kind of grouped together, but that's just convention. Now, soft tissue can do a number of different things depending on how much load we do or do not expose it to other types of things. So metaplasia is the transformation of tissue from one type to another that isn't normal for that tissue. We don't talk about this very often in healing. Dysplasia, if something is dysplastic, we get an abnormal development there. If you get a growth, that could be considered dysplastic. Hyperplasia is when we get a proliferation of normal cells in normal tissue arrangement. So there's some question about strength and conditioning. Does it cause hyperplasia? Do we get more muscle cells? What we found to be true is that we don't get more cells, they just change in size. So that's referred to as hypertrophy, where we get an increase in the size without changing the number. And then the converse of that is atrophy, where the size of the tissue cell, the size of the tissue decreases macroscopically because the cells are shrinking in size due to disuse or misuse. Now, we said tissues are different. Cartilage has a limited capacity to heal. It has very little to no direct blood supply. So as a result, oftentimes we consider damaged cartilage to basically be a lost cause. Now, there are emerging technologies where we have cartilage replacements and things of that nature, but in general, historically, we've said damaged cartilage usually doesn't heal. And if it does heal, it heals very slowly, and only certain parts of that cartilage, depending on where your injury is, are going to heal. If it involves subchondral bone, then it may heal a little bit better. If it's just the articular cartilage itself, then probably not. Ligament, on the other hand, it's very tough and fibrous. The problem with ligament healing is if we don't load it enough, then it won't remodel appropriately, and the end result is a ligament that's weak. If we overload it too much during the healing process, we re-injure it. Oftentimes, an athlete sustains an ankle sprain and they'll be back to full participation within 2 or 3 weeks and feeling relatively good, but we have to understand that that remodeling can take upwards of a year in order for that to be fully recovered, fully different. Lots of times if we've had a surgical repair, then that surgically repaired ligament tends to be stronger because we have decreased scar formation. If we've got a ligament tear within the joint, synovial fluid will usually dilute that hematoma, prevent clotting and spontaneous healing. So if we've got a ligament that's outside a joint capsule, then that may alter the healing process. Exercised ligaments are stronger. Again, getting back to that concept of optimal loading. Ligaments are considered static restraints. You don't have to do anything to your anterior talofibular ligament to stabilize your ankle. It just is. It's stable. If it becomes injured, then your static restraint is compromised. The flip side of that is muscles that cross that joint are dynamic stabilizers. If I contract my peroneal muscles that cross the ankle joint, then they add stability. But the problem with that is that I have to actively contract those muscles. It's not just going to occur. It's an active process instead of a passive process. So in the case of a ligament injury, we want the muscles to be strengthened to provide or take up the slack because that ligament has been injured. Okay. Skeletal muscle has an excellent blood supply, as you might expect. We get an initial bleeding that's followed by proliferation of ground substance and fibroblasts. We'll end up with regeneration of new myofibrils, and eventually that collagen will mature and orient along the lines of tensile force. Okay? Healing here could last upwards of 2 months depending on the muscle injured, but it's not uncommon to see bruising, have some tenderness, have a palpable defect there that would indicate that we've got an injury in the tissue. Tendon, on the other hand, is not as vascular as muscle in most cases. This is a dense fibrous union of separated ends, and we need plenty of collagen for that structural support so that we've got good tensile strength. If we've got too much collagen, we end up with fibrotic tissue, and that may not glide well. It's relatively just unhealthy tissue. Initially, that injured tendon we may have what's called an adhesion, where surrounding tissues are kind of globbed together. They grow together. And over time, with movement, we can gradually separate that tissue. That tensile strength of that healing tendon is usually not very good until upwards of a month. So an initial tendonitis or an insertional pain or injury may take several weeks before we start loading it to comparable levels again. Nerve, on the other hand, can't regenerate after injury. We can get regeneration within a nerve fiber, and where that injury is to the nerve cell can make that regeneration a lot more difficult. So in order to get regeneration of the nerve fiber, the optimal environment again is there. That rate of healing occurs at a very slow pace, 3 to 4 millimeters per day. So if you've got a long peripheral nerve fiber down into the foot, it may take more than a year in order for that fiber to fully regenerate. Central nervous system nerves don't heal as quickly as peripheral nerves, and we know that in most instances, CNS nerve injuries just don't regenerate. There's lots of research in this area, but once that happens, it's typically forever. Okay. Now we can do lots of things to modify soft tissue healing. We have to figure out how best to mobilize them without making the injury worse. We have to figure out best opportunity to optimize that healing environment. Some organ disorders, blood conditions, can slow or inhibit the healing process. Patients with poor diets may take longer. If the patient's diabetic, their peripheral vascular circulation, it's going to be poor. And so that may make them a notoriously slow healer. So there's lots of things we can do to try to intervene here. The first is using drugs. And I say first, the first we'll discuss. That doesn't mean that's our first option. But you'll see NSAIDs prescribed lots of times for acute injuries. Okay, you sprain your ankle, take an Aleve, take an ibuprofen. It's an anti-inflammatory. We may also use antiprostaglandin agents to combat inflammation. That's one approach. Another approach may be to use what we call therapeutic modalities. Now, that's a full standalone course in the athletic training curriculum here. In this course, it's one chapter in the textbook, and we'll talk about ways to apply these modalities for various injuries. But we can use hot, superficial heat, deep heat, cold. We use cold to slow inflammation. We know that heat early on actually facilitates acute inflammation. Heat is a vasodilator, and if we've already got an area that's vasodilated and swollen, heat will actually make that worse. We also can use electrical modalities, electrical stim, therapeutic ultrasound, sometimes referred to as an acoustic modality depending on the textbook that you look at. But lots of different tools that we use to try to usually treat pain is what we're dealing with more often than not, at least indirectly. So for instance, if I apply cold to an acute injury, then I am going to alter pain perception, but it's indirect. If I've got a massive swollen ankle, then I'm going to get sensory information sent to the brain just simply because my ankle is so distended, so large, and triggering vasoconstriction actually prevents that from happening. So even though I'm not directly trying to treat the pain, indirectly that's the result I'm getting. Alright, another approach, and frankly it's my favorite, is therapeutic exercise. So you can use drugs, you can use modalities or treatment techniques, you can use exercise. The major aim here is pain-free motion, full strength and power, extensibility of the associated muscles or joints. A mobilization, we know if we break a bone, we've got to be casted, okay, in most cases. There are, however, there's an adverse impact to being non-weight bearing or not using muscle. Early mobilization, which is controlled, can enhance healing. So putting them in a removable splint, and then being able to do range of motion exercises and light therapeutic exercise in a controlled environment and then putting them back in the splint before they leave is typically preferred, as long as you can trust them to wear the immobilizer, to putting them in a rigid cast that can't be removed. Some other more contemporary approaches include prolotherapy and PRP. Okay, so with prolotherapy, they will inject an irritant, this non-pharmacological solution, dextrose, phenol, glycerin, lidocaine, and the intent here is to actually increase the inflammatory response to trigger healing. Sometimes if we end up in this kind of chronic low-level inflammation phase, then we need something to break that cycle. This is used to strengthen, weaken connective tissue, reduce pain. These injections are usually repeated, usually on the order of every 3 to 6 weeks. There's not a lot of evidence that tells us that this is terribly effective, and a lot of insurance companies won't pay for it. So if this is suggested, it might be worth doing a little research, or you could end up having to pay for it out of pocket. Along the same lines, probably with a little bit better support, is PRP injections, but this is still kind of on the cutting edge, so there's still a lot of research left to be done here. So this uses the patient's own platelets to promote this natural healing response. So a little bit of the patient's blood's drawn and then centrifuged to separate the blood into its components. So we get plasma, platelets, white blood cells, red blood cells. The red blood cells are drained away. The platelets, white cells, and plasma are centrifuged again. And then an anticoagulant is added. So then that platelet-rich plasma is re-injected into the immediate vicinity. Okay. These platelets release bioactive proteins, and the idea here is that we're actually getting some growth factor response. Okay. Oftentimes pain will actually go up for a few days after the injection, and the number of injections depend on the type of condition, severity, and the age of the patient. I have a friend in Canada. They've got socialized healthcare there, but he was considering this for long-term shoulder pain that he's had, and he was telling me that there it's roughly $2,000 US per injection. Here in the States, about $1,000 per injection. Insurance may or may not pay for these. There aren't a lot of studies that show significant long-term evidence to the approach, but it's an emerging technology, and I'm sure you'll learn more about it in the years to come. All right, now bone healing follows the same phases as soft tissue healing, and it's actually a less complex process if you really think about it. We begin with this initial hematoma. Over time, that will gradually start to proliferate, and we end up with a callus. First a soft and then eventually a hard callus. And then over time, that callus will start to solidify and ossify, and then it will eventually remodel. We'll forever have evidence of that fracture, but with appropriate loading, the hope is that it can be at least close to as strong as it was before the injury. So the first thing we have is this hematoma formation. So that medullary cavity, the surrounding tissue, starts this process within the first 48 hours, and we end up with a big disruption of blood supply in the area due to the clotting vessels, the cellular debris. So if you look at this picture, you see whether these are bone fragments or even on the microscopic level, tissue's been damaged here. Osteoblasts fill the internal external calluses to serve to essentially splint the body part from within, and calluses are formed by bone fragments that serve to bridge this fracture gap. Now, we really need good approximation here. If we've got a fracture that is well out of position, if it's an open fracture, whether we've got rotation or something else, then that's going to make this process much more difficult, because those bone ends need to be in position in order to have appropriate healing. Okay, so this initial soft callus turns to a hard callus as those osteoblasts keep laying down bone and replacing that cartilage that was kind of a stopgap measure. Now, bone adapts to those applied stresses. Unfortunately, during this time, we can't really apply stresses. So I think I showed you pictures of my son's tibia from a couple weeks ago from the trampoline park. Now, unfortunately, he's been in a cast for going on 6 weeks now. He hasn't been able to load bear at all, because to do so would probably disrupt that alignment. He was reduced under sedation in the hospital, and those bone ends are where they need to be. And as long as he doesn't bear load, then everything should be good. Now, the time required for this process to occur does depend on a number of different factors. Severity and the site of the fracture. In his case, it was a pretty severe fracture, and it involved a growth plate, but because he's young and already has open growth plates, not as big of a deal. So time can range pretty dramatically here, from 3 to as much as 8 weeks before we end up with this soft and eventually hard callus. Okay, so we have to immobilize a fracture right away, and that has to be present until that hard callus is there. In most instances, that's going to be a fiberglass or even a plaster cast. We don't use a lot of those anymore, but in some instances it may be a removable splint. However, the clinician has to be certain that we don't have poor blood supply, poor immobilization, or an infection. Especially in the case of an open fracture, that risk of infection goes up. And we know that that a broken bone can limit participation for up to several months. Okay, if they've got poor blood supply, that bone may die, and we may end up with healing not occurring. This is referred to as avascular necrosis. A means without vascular blood. Necrosis means tissue death. So we'll see this a lot of times in wrist fractures that go misdiagnosed or undiagnosed. We'll also see this in the head of the femur in adolescence, and then also the talus of the foot, and then sometimes bone fragments become avascular. And these are relatively rare in healthy young athletes, except for that navicular of the wrist. Another potential detriment to healing is poor mobilization. So we want those bone ends to be in proper position, and then we want them to stay there for the duration of that 3 to 8 weeks until that hard callus forms. Now, when they initially casted my son, they put him in what's called a bivalve cast, and basically I'm using my arm because you can see it. If they were to cast his entire leg and then they split it down both sides so that you could remove it right away. And the thinking was that he was swollen at the time he was casted. Well, that swelling's going to go down relatively soon. So this would allow you to tighten that cast down further. So he had two pieces surrounded with an ace bandage. And then after a couple of days, the ace bandage was removed and then wrapped tighter so that you can compress that area and get a better immobilization there. If we've got a lack of immobilization and those two bone ends are allowed to move, then much the same thing that would happen if you had a cut or a scrape on your arm or anywhere on your skin. If you were constantly picking at that, it's going to disturb and slow the healing process. So it can result in what's called a non-union, where those bone ends don't grow together. Or in some instances, it will result in a bone deformity, where it may heal in an improper position. Another detriment here is infection. So severe strep and staph infections can certainly occur. We can end up with an osteomyelitis. Antibiotics have reduced the risk of infections, but because we've seen an increase in staph resistant, in methicillin resistant staph, we've seen strains of infections that are more resistant to our antibiotics, then this becomes a concern. So just because it's a closed injury doesn't mean they're immune to infections. If soft tissue alters that bone positioning, then surgery may be the only way that we can get proper union in that bone. Now, stress fractures are kind of a different animal. These are cyclic forces, compression, tension from muscle pulling. We may end up with constant stress throughout the body just from muscular action can impact bone. We'll see this oftentimes in jumpers. They may end up with an insertional stress fracture or a tension issue associated with that predominant jumping knee. So if the osteoclastic activity isn't in balance with the osteoblastic activity, in other words, the rate of teardown exceeds the rate of buildup, then that bone is actually going to become weaker. So ordinarily, load bearing causes positive adaptations in bone. But if we are stressing the bone beyond the rate and beyond the level that the body can heal it or make it stronger, then the net result is weakening. Okay, so to treat a stress fracture, we have to be able to restore that balance between the osteoblasts and the osteoclasts. Now recall that the osteoblasts are the cells responsible for laying new bone tissue down. And the osteoclasts are removing those injured cells or old cells, whatever, tearing down. Okay, so there's this balance we have to strike. As long as buildup equals the rate of tear down, we're okay. And in the case of positive bone remodeling, buildup is exceeding the rate of tear down. Just like in a city, if we're trying to rebuild things stronger, that's fine. But if the teardown crew is able to clear 2 blocks a day and the build-up crew can only build up 1 block a day, it doesn't take time. It doesn't take very long before we see far more torn down than built up, and that's exactly what happens in the case of a stress fracture. So we may need to decrease activity, eliminate those factors that cause that stress. So for me, I was training for a 5K, and I've never been a runner. I've always been a basketball player, team sports guy, and so running was something I had to do for punishment. I never was much of a distance runner. And so I had finally started running 5-6 days a week, and before I knew it, that accumulation of micro trauma resulted in a minor stress reaction. So what I do? Stopped running. My knee feels better. So I got to find a different, other than weight training, something else that I can do. But I don't know that I'm ever going to be a marathoner. Alright, so that leads us to pain, kind of the last little section here. Few slides here. Pain is a major indicator of injury. It's individualized, it's subjective. One patient can say, that injury is a 9 out of 10, and another can say it's a 2 out of 10, and they may have the exact same condition. More often than not, pain is the reason they're seeing you. So we can get pain from a number of different sources: cutaneous, deep somatic, visceral, psychogenic. Cutaneous pain, they'll usually describe it as sharp, bright, burning. Usually we attribute that to nerve-based pain. Deep somatic pain, they're usually not able to pinpoint where that is. So if they've got a tendonitis in their shoulder, for instance, they won't be able to tell you with one fingertip it hurts here. They'll show you with their whole hand. Visceral pain, this is that deep kind of gut pain, organs, and then it may radiate and diffuse elsewhere. And then psychogenic pain, there's no structural reason for the pain. This is basically a wiring problem, not a 2x4 problem. The issue isn't in the structure. The issue is in the pain perception. This is, and it's not even neurological, but it's rather in the emotional rather than the physical. Okay, so much like we talked about with inflammation, pain can also be acute versus chronic. But we do have some conventions here. So acute pain lasts less than 6 months, and then chronic pain extends beyond that. Chronic pain, according to the International Association for the Study of Pain, is defined as pain that continues well beyond the normal healing time. So it's kind of pain that's outlasted its usefulness. In and of itself, pain isn't necessarily a bad thing. It tells us when to stop doing things. It should signal when we are overloading structures in the case of a stress fracture, if we're smart enough to heed its warning. Now, pain can be referred, and that's where we feel it in a location other than where it actually hurts. Pretty common that back pain will manifest somewhere in the legs or in the feet. It can elicit motor and sensory response. We can end up with inhibition. Your body starts to shut down muscles so that hopefully you'll stop doing whatever it was that caused the pain to begin with. 3 types of referred pain: myofascial, sclerotomic, and dermatomic. We won't really get into that. That's in your textbook. You can take a look at it if you want to, but that's really kind of deeper than this course needs to be. Now, nociceptors, these are pain receptors located throughout the skin, the muscle, soft tissue, the periphery. Primarily, though, here we're talking pain receptors in the soft tissue. Okay, we see this also in the meninges, the periosteum, skin, the teeth, some organs. I included muscle in there. the Golgi tendon organs and the muscle spindle fibers, they're not really nociceptors, they're not for pain, but they are for proprioception, and that's a closely related process. Okay, so pain information gets transmitted to the spinal cord via myelinated C fibers and A delta fibers. And you can think of C fibers as kind of smaller diameter, more for chronic pain, and A delta fibers are for acute. They're larger, faster conducting. Nociceptor stimulation results in the release of substance P in the spinal cord. Now, in order to control pain, we have what's referred to as the gate theory of pain control. And the key to the gate theory is right here in the spinal cord, what's referred to as the substantia gelatinosum. So we get sensory information that comes in from the periphery. It enters in these A beta, A delta, and C fibers. So this is all coming in, and the SG basically determines what goes up to be interpreted as pain and what doesn't. So if we can essentially close this gate, then even though the stimuli that caused you to feel that pain to begin with is still there, you don't feel it. Okay, so it's not healing anything, it is simply altering the perception of pain. So this occurs at the level of the spinal cord. So if you notice, in this example, the A beta fiber, we see this plus sign here. That means those pain signals are sent up, and our brain interprets that as pain. But the C fibers and the A delta fibers, we notice that is inhibited, so it's not sent up. So we still feel a little pain, but it's not as severe as it was. Okay, so the question becomes, how do we flood this gate so that it essentially is closed? And the idea here is, sorry, I'm jumping all over. The idea here is sensory information of any type can close that gate. Okay, so this could be low-level oscillations, like we would do in range of motion exercises. Could be electrical stimulation. It could be gentle stretching. Lots of things we can do to close this gate. Okay. Another thing we look for in the terms of pain control is the release of beta endorphin. Okay, so we know that noxious stimuli, pain-causing things, can trigger this endorphin release. And if we get this endorphin release, then the stimulation of pain sensory fibers is required. So we get these strong pain prevention or analgesic effects as a result of this beta endorphin. This is a reason why a lot of times in the middle of participation, someone might sustain a severe injury, or we see this oftentimes in a case of a car accident. You will get this big endorphin release, and it essentially stifles the perception of pain. Even though the structures are injured, you don't sense it. Okay, and so if that occurs, then once this beta endorphin wears off, once its influence is minimized over time, then it starts to hurt. So you wake up the next morning and you realize, oh wow, I was injured. So we'll see this oftentimes in athletics as well as car accidents. Okay. So in terms of pain control, self-report is our best tool. We don't have a tool to, I can measure your height, but I can't measure your pain. The best I can hope for is to have you judge it on what's called a visual analog scale. On a scale of 0 to 10, 0 being no pain at all, 10 being the worst pain you've ever felt in your life, what's your number? Now, I can't compare that from one patient to another, but for that patient, that's reasonably reliable. So I check you today and you're a 6, I check you tomorrow, you're a 3, we're trending in the right direction. Lots of different tools we can use to assess this. Multi and unidimensional questionnaires so that we can figure out what makes it worse, what makes it better. Lots of tools here. Now, for treating pain with modalities, we need to have a clear rationale for use. We don't just slap stem on people just because we don't have anything else to do. Understand the physiology. If there's If there's a justifiable reason for using it, then that's fine. If there's not, then do something else. We don't want to use modalities all by themselves. They are an adjunct. If I can treat their pain, hopefully they're better, and then I can utilize therapeutic exercise or manual therapy in order to further improve that healing environment. So lots of different things we can use here. Our hot and cold therapies, our electrical modalities. You'll see other people use acupuncture, deep massage techniques and release techniques. Some of our like Graston technique and other types of massage related modalities, cross fiber friction massage. Drugs are another option, and frankly they're never my first, because you're really just masking the symptoms. You're not treating the source, and that is a recipe for addiction. And a lot of pain meds are highly addictive. These can be oral or injectable. A lot of our analgesics and anti-inflammatory agents, we can buy these over the counter. Aleve and ibuprofen being probably most common. We want to work with our team physician, and in some instances a pharmacist, to make sure that they're taking the appropriate medications and that we aren't undermining their long-term healing to treat their pain short-term. Alright, last one, psychological aspects of pain. Sometimes you'll have a patient, I've had very few in my career, but I've had a couple, where the source of their pain was psychological. Okay, there was no structural pathology. I also know that no two patients are the same, and it is subjective. It just depends on them. Sometimes even within that same patient, they can be have a high pain tolerance one day and a relatively lower one the next. There are a number of theories relative to why this happens, but frankly this is an emerging area of science, and a lot of our patients in the athletic environment, especially if you're a college level athlete, are able to condition themselves to endure pain and block sensations. They're used to the normal aches and pains of participation. Consistently, students in our program notice the huge difference between high school football players who are freshmen and high school football players who are sophomores, juniors, and seniors. And they note that the freshmen haven't yet learned how to deal with the typical sensations associated with playing high school football. And the older student athletes have. Okay. Now, that's not to say that everything about that is great. Okay, we know that there's certainly plenty of reasons to say that being tough and being able to endure pain is a positive character trait. But we also know that sometimes those pain signals are there for a reason, and well, not sometimes, most of the time. And to ignore them means we're leaving things untreated. So there's certainly a learning process here where the athlete understands the difference between pain and soreness. Soreness is to be expected. Pain, on the other hand, is usually a sign of tissue trauma. So we want to be cautious there, and then be specific to the tissue we're talking about, identifying what that source is, how long are we going to have to optimize loading or alter loading, and then how long is it going to take for them to recover. Alright, that's it for this week. Hope everyone is doing well and keeping up. I look forward to seeing you next week. Have a great day. Bye.